Welcome back to another masterclass. I'm Dr. Naveed Ul Zafar. Today I have two cases for you that are not your typical neck pain or shoulder pain. These are the cases that walk into your clinic, and if you're not thinking beyond the textbook, you will miss them completely and the patient will keep suffering. The first patient feels like the room is spinning, but every test by the ENT and neurologist comes back normal. Where do you look next? The second patient has tingling in his arm, but the cervical scan is clean. Also, his wrist tests are negative. The problem is hiding somewhere else, somewhere most physios forget to check. So, grab your notebook, pause when I tell you to, write down your best guess. Let's begin. Case 1. A 40-year-old female presents with a 3-month history of dizziness. She describes it not as true vertigo, but as a sense of imbalance or floating that gets worse when she turns her head to the left or looks up. She also has a dull ache at the base of her skull. Vestibular tests and ENT examination were all normal. On examination, she has restricted upper cervical rotation to the left and trigger points in her suboccipital muscles. What is the most likely source? Option A, benign paroxysmal positional vertigo. Option B, cervicogenic dizziness. Option C, Meniere's disease. Option D, vertebro-basilar insufficiency. Pause, think, what makes the dizziness worse? What tests were normal? Write your answer. Correct answer is B, cervicogenic dizziness. If you chose A or D, I completely understand. This is a diagnosis of differentiation. Option A, benign paroxysmal positional vertigo. This is the classic room spinning vertigo triggered by rolling in bed or looking up. It's an inner ear problem, but our patient's ENT and vestibular tests are normal. The dizziness here is triggered by neck movement, not just positional changes of the head. BPPV lasts seconds. This is more constant imbalance. Option C, Meniere's disease. Meniere's includes tinnitus, hearing loss, and a feeling of fullness in the ear. Our patient doesn't have these. She has neck pain and restricted upper cervical movement. It's a neck problem, not an ear problem. Option D, vertebro-basilar insufficiency. This is the dangerous one. VBI is a lack of blood flow to the brainstem, and it can cause dizziness, but usually with the 5 Ds: dizziness, diplopia, dysarthria, dysphagia, and drop attacks. Before we even test the neck, we screen for VBI. She has no other neurological symptoms and a normal cranial nerve exam. So VBI goes down the list. Cervicogenic dizziness. How does the neck cause dizziness? The upper cervical spine, especially C1 to C3, has tiny sensors, also known as proprioceptors, that tell your brain where your head is in space. If you have tight suboccipital muscles or a stiff upper cervical joint, these sensors send wrong signals to the brainstem, conflicting with your eyes and ears. Your brain gets confused and you feel dizzy or off balance. Here's how we test it. A simple test is the smooth pursuit neck torsion test, or just assessing if repositioning the head to neutral eases the dizziness. If a patient says, I feel drunk when I turn my head, think cervical. Treatment is manual therapy to the upper cervical spine and deep neck flexor training. Clinical Pearl. If a patient has dizziness, normal ENT tests, and neck pain or stiffness, it's cervicogenic dizziness until proven otherwise. Don't just hand them over to the neurologist, assess the neck. So, the neck can cause dizziness, but what if the neck is not the main site of compression for the arm pain? Case 2. A 28-year-old software engineer presents with vague pain and tingling in his right forearm and the ring and little fingers. He slouches heavily. Neck MRI is normal. Cervical radiculopathy tests are negative. However, when you bring his arm into full abduction and external rotation, his radial pulse diminishes and his tingling starts immediately. What is the most likely site of compression? Option A, carpal tunnel syndrome. Option B, scalene triangle compression. Option C, costoclavicular compression. Option D, pec minor space compression. Pause, think about the surrender position. What muscle is stretching right now? Write it down. The correct answer is D, pec minor space compression. Let's break it down. Option A, carpal tunnel. The symptoms are in the ulnar side. Carpal tunnel affects the median nerve, which innervates the thumb, index, and middle fingers. And the neck MRI was normal, but wrist tests weren't positive. Option B, scalene compression. True neurogenic thoracic outlet syndrome often starts in the scalene triangle. The AdSense test would be positive. Our patient's tests for the neck are negative. The provocation is pure arm movement. Option C, costoclavicular. The space between clavicle and first rib. tested by the military brace position. This is common in people with dropped shoulders. Our patient symptoms come on with arms overhead, a position that stretches the pec minor. Pec minor space. Look at the anatomy. The nerves and vessels don't just leave the neck and magically appear in the arm. They run under the pec minor, which attaches to the coracoid process. If you are slouched, the shoulder rolls forward, the pec minor tightens, and when you raise your arm, it stretches over the tight muscle and gets sandwiched. This is called Wright's test or pec minor's test. You do this test by taking the arm into hyperabduction. If the radial pulse disappears or symptoms start, it's positive. Why? Because that puts the pec minor on maximal stretch, trapping everything underneath. This is a real world win. For this patient, you won't need to touch his neck at all. You will release his pec minor, tape his shoulder back, and retrain his posture. If you had just treated his neck because he had arm tingling, you'd have failed. You must look at the whole chain from the neck through the first rib to the pec minor. So, your takeaways: number 1. Symptoms in the ulnar side with a normal neck MRI look lower. Number 2. Wright's test is key for pec minor thoracic outlet syndrome. Number 3. Treat the slouch, release the chest, strengthen the back. 2 cervical cases that are out of the box: dizziness from a stiff neck and tingling from a tight chest. This is the physiotherapy of the future, connecting the dots. Comment below which of these 2 conditions was new to you today. I'm Dr. Naveed Ul Zafar. If you want to stop memorizing and start understanding, subscribe, hit the bell. I'll see you in the next one.